Welcome to the Australian Prescriber Podcast. Australian Prescriber, independent, peer-reviewed and free. In a pandemic, we often think about the people who are at greatest risk and what we can do for them. When any infection comes along, it's natural to think about what it means for people receiving immunosuppressive medications for autoimmune disease. As a rheumatologist and clinical pharmacologist, this personally goes through my mind a lot. But it's clear that this is a question that affects a large number of people in our society, and it's particularly relevant when we think about the possibility of what living with COVID in this world might look like. So what do we do for people with autoimmune disease? Should we worry? And is it different depending on what immunosuppression they're getting? I'm David Liu, your host for today's podcast, and I'm here with two experts from the University of Queensland. Associate Professor Philip Robinson, a rheumatologist from the Royal Brisbane and Women's Hospital and at the University of Queensland, is also the chair of the steering committee for the COVID-19 Global Rheumatology Alliance, meaning he's been directing efforts internationally to get data-driven answers in this space. To give us the flip side of this as well, we've got Dr. Evan Bursell, an infectious diseases physician at the Princess Alexandra Hospital in Brisbane and also a microbiologist at Sullivan Nicolaides Pathology. Together, they've written an early release article in Australian Prescriber out on August the 18th, 2020, about the management of autoimmune disease during the COVID-19 pandemic. Philip, Evan, welcome to the program.
Thank you very much.
Thank you.
So around the country, around the world for that matter, there are clinicians who treat autoimmune disease patients who are saying, what should we tell our patients? What should we do for our patients? And we have these patients with autoimmune disease who are often pretty scared, understandably, given that they have something which changes their immune system. So maybe I can ask both of you in turn. So Evan, maybe I can start with you. As an infectious diseases physician and microbiologist, how do you see this paradigm with these people with immunosuppression?
I think the easiest way to start thinking about it and reducing and addressing these patients' anxieties is to reduce their risk of infection in the first place. And a lot of our article does focus on simple measures that patients can take themselves to reduce their risk of contracting the infection in the first place. And I think that's really has to be at the forefront of everyone's mind. If you can prevent infection, then obviously you don't even have to worry about the downstream effects of what might happen with your risk in the context of your immunosuppression. So things that are crucial for that are things like maintaining excellent hand hygiene, maintaining physical distancing when appropriate, and following all the good public health measures that are really well promoted at the moment in the context of this pandemic. Staying home when you can and when it's appropriate, avoiding large crowds, using masks outside and in contexts where it's recommended. So I think all that's very crucial before you even think about what your risk might be from your immunosuppressive medication.
Mm-hmm. It's the simple stuff which can make the real difference in a pandemic like this, I guess.
Absolutely. And that's the same, it's the same theme for lots of infections, but obviously it's heightened in the current circumstance. And, the things that patients might have to do might differ dependent on the local epidemiology for COVID in their area. So things might be a little bit different in terms of the steps people on immunosuppressive medication should take, whether they're living, say, in a hotspot in Melbourne, for example, at the moment, to living, say, in perhaps outback Queensland, where there's a very little risk of acquiring COVID in their community.
So, Philip, maybe I can switch to you at this point to ask, well, in terms as a rheumatologist, do you think about the different immunomodulatory therapies that you use in different contexts in terms of infection? Where does that sit? And once we've kind of got past the simple stuff, do you change the way you approach things?
Well, I suppose the first thing to think about is it's not a one-way street when you think about being on immunosuppression, because you've clearly made a decision to go onto immunosuppression based on the risks and benefits that you feel for the disease. So whether that be rheumatoid arthritis or whether that be ANCA vasculitis, those things really play into it. So part of what you want to think about is also the reasons why you're even on the medication that you're on and the complications and adverse events that you're trying to think about. I suppose the first thing, and this applies to everyone who's on medication that might affect their immune system, is that there has been very universal opinion amongst experts, and that if you are not infected, you should not change your therapy. And part of that comes down to the fact that you're on that medication for a reason, and depending on the local characteristics that are important in your area and the sort of the public health aspects of it, your risk of an adverse event from discontinuing medications may well be, and is probably much higher than your risk of an adverse event from actually contracting COVID-19. So it's really been universal that you shouldn't be discontinuing medications based on the fact that you're worried about what the outcome might be. And if that's a concern for you, and obviously every situation is different, then I think it's important that you actually talk to your doctor about that, because your doctor has a really good understanding about the potential adverse events that might come from discontinuing some medication versus others that patients might not necessarily appreciate.
If I can just add, and I think it's important to, as clinicians, to portray what the risk might be for the patients and put the risk in context. I think in this pandemic, fear and anxiety spreads really, really easily, and you get it every day, even from other clinicians, in fact. And perceived risk is often a lot higher than what actual risk might be. So if you can put into context, perhaps the prevalence of COVID in your particular area for the patient to, help potentially allay their fears about continuing their immunosuppression for what presumably is an excellent reason to be on in the first place, as you mentioned, Phil, then that can help in those discussions with the patients. So, I mean, for context, for example, I guess our prevalence of COVID in Australia, is really far less than 1% of the population. So we're looking at probably even less than 0.1%. And this is very different to what's happening overseas, where there's been, up to sort of 10% of the population.
I mean, all of that seems really important for our frontline clinicians. I mean, there are hundreds of thousands of Australians who are taking some form of immune modulating therapy, and I'm sure a large proportion of those would have gone to their local GP, to their local pharmacist, and asked questions when the pandemic started about what they should be doing about their medication. So I don't know. I mean, I think I draw a lot of reassurance, as I'm sure a lot of people do, from that. And especially thinking about patients who we're going to start on immunomodulating therapies, and we've got a choice potentially of which agent we choose. So how do we assess the infection risk overall, especially keeping in mind that maybe infection risk for bacterial infections might not be the same as for viral infections, that within viral infections, the risk between different types of viral infections might be different. Is that the case for COVID?
Yeah, it's interesting. So obviously, there's some good association between certain immunosuppressions and risks for certain infections. For example, TNF inhibitors, a strong risk of TB reactivation, rituximab, a risk of reactivation of hepatitis B. So these are things we always screen for to reduce the risk of that happening in susceptible populations. Viral diseases outside of hepatitis B, perhaps, and respiratory viral illnesses haven't, been subject to that level of knowledge about particular risk previously. And the predominant one we see from a pandemic point of view, or a yearly epidemic point of view, is influenza. And that's a little bit different because we do have a vaccine that's efficacious to some extent anyway, that can reduce patients' risk. So we haven't, prior to this pandemic, been able to draw on a lot of information about what the particular risks might be from particular immunosuppressive agents. And I think that's really the usefulness of the data collection and study that Philip's team has done in terms of teasing out what really are the actual risks for patients on these medications.
So, I mean, that's the kind of thing we're dealing with right now, and that we've got to try and rapidly make some data-driven decisions, and how we've never seen SARS-CoV-2 before. I guess there's some precedents from SARS-CoV-1 and other coronaviruses, but they don't necessarily translate as well. It sounds like that we really need to rapidly get real-world data in place. I mean, that's the kind of stuff that you're doing at the moment, Philip, isn't it?
Yeah, that's right. We are just about to recruit our 4,300th patient across the global registry. So we've been able to accumulate quite a bit of real world data. Of course, it has its limitations because it's clinician inputted data, but certainly we've seen consistent signals for some agents across multiple different registries. And I suppose the important ones to think about are glucocorticoids, so prednisone. We've seen increased risks for poor outcomes, including hospitalization and death in the COVID-19 Global Rheumatology Alliance Registry. We've also seen that in the Secure IBD Registry. So I think that's a pretty consistent signal that we're seeing. We've also seen out of the IBD registry information that would suggest that sulfasalazine might be an increased risk for poor outcomes. Now, at least in the published data to date, it's a little bit mixed, but it certainly, I'm aware of other data that might also support this too. So I think we need to be cautious thinking about sulfasalazine too. And on the flip side of that, I think there are some agents that also look like they may well be protective. Now, again, we don't have good controls to look at the data, and so this is all relative. But at least from the point of view of biologics, there's data that looks like TNF certainly doesn't seem to increase your risk and may in fact decrease risk of poor outcomes. And that probably relates to the severe hyperinflammation state that is often driven by cytokines. And so agents that target things like TNF probably are able to dial down that and decrease the complications that come from the hyperinflation that really drive the very poor outcomes that we see in COVID.
So before we go on, let me get the 1,000-pound elephant in the room out of the way. Let's talk about hydroxychloroquine very briefly. Is there something that we need to be worried about starting patients on? I think there are a lot of people who have seen a lot of the talk about adverse events from hydroxychloroquine and COVID and are potentially concerned about starting it at this point in time. And on the flip side, there are some patients who might not ordinarily have considered hydroxychloroquine for their disease and are seeking it out. Or what would you say to them, Philip?
Well, David, you'll be well aware that we've been using hydroxychloroquine in rheumatology for longer than probably you and I have been alive. I think it was recognized during the Vietnam War to be useful in autoimmune diseases, particularly rheumatoid. So from that point of view, it has had a long history of very safe use. Now, it's been recognized when you use it in very unwell patients at a very high dose, it seems to have negative cardiac outcomes, including prolonging your QT, especially if you combine it with other QT prolonging agents. So because of this discussion, patients have come in and said, what is this drug I'm on? This is a problem for the heart, and I said, well, look, we've been using it very safely in patients that have had rheumatic disease on the doses that we use, which is generally maximum 400 milligrams. And we've been using it for a very long time. But if you go and look in the literature, including very recent literature, it does prolong your QT by itself. And then when you use it with azithromycin, for reasons that I'm not 100% clear about, but anyway, if you choose to use it with that drug, you will prolong the QT even longer, even further. So I think that this is a tale of two separate uses. And one is a relatively safe use in rheumatology, and the other is when you give it to a critically unwell person with other agents who are often elderly and have other comorbidities.
I think it's really interesting what you said, Phil, because we talked to this. David introduced me being perhaps on the flip side, an alternative view, but I think for most of this discussion, we firmly believe the same things. But it's interesting, you end up having to discuss with your patients that are on hydroxychloroquine the safety of it in light of this poor level of publications that have come out in relation to hydroxychloroquine and in the context of COVID, because we do see the flip side there is we tend to have to deal with people wanting to use hydroxychloroquine for COVID, and you guys have to deal with patients potentially thinking about stopping it, having seen adverse outcomes from these trials. So I find that really fascinating. I hadn't actually considered that your patients might be worried by the hydroxychloroquine trials.
Well,
Yeah, and they say, "Are you putting me on this Trump drug? Is that what you're doing? Do I want the Trump drug?"
it's really hard to be able to shape this public discussion in a nuanced way about something like hydroxychloroquine, and I guess we've got to be the light of sensibility to our patients. Well, let me put another one to you, which has been a little bit in the media. So Philip mentioned glucocorticosteroids, and there's been a lot of talk about dexamethasone from the recovery study, looking at the potential benefit from dexamethasone, something which is being used in clinical practice at the moment in COVID-19 infected patients. So, Evan, do you think that it's hard for people to resolve that result with the results about people on steroids being at greater risk of contracting COVID-19? And do you think that that signal about corticosteroids was a predictable one as far as COVID-19 is concerned?
I'm not sure if anything's particularly predictable at the moment with COVID-19, and we've seen contradictory studies in flu, for example, with the use of steroids. But I think that the recovery studies result was really robust, and most sensible places have moved to instituting that as a therapy in patients where it's indicated. I don't really think it is inconsistent with what's been seen in Phil's registry, though, because we know that not everyone benefits from dexamethasone. So the recovery trial showed benefit in patients that required supplemental oxygen, but in fact, no benefit for patients that didn't, and in fact, a trend to worse outcome if you used it in the early stages in patients that did not require supplemental oxygen or invasive ventilation. And so, it's difficult to extrapolate that on patients that are having it prior to being infected, but you could think that they're sort of analogous to those that are on it in the early phase where there wasn't a benefit. And I guess it's not known whether the dexamethasone effect applies to all other steroids. It may well, but I don't think we know that from the data we have as yet.
Mm-hmm. I'm sure there is a lot more nuance to drag out. And I think probably one area where it gets a bit complicated is when we think about the biologic and targeted synthetic agents that Phil and I prescribe to our inflammatory arthritis patients, amongst others. Actually, Evan, I might ask you this first. Do you think that in terms of we've got different agents targeting different parts of the inflammatory response, do you think it's plausible that there might be differences between different agents? And would we expect to see signals when it comes out in the real world evidence?
I think conceptually there are some potential differences, and there's been a lot of interest in, things like tocilizumab and some TNF inhibitors, and there's trials involving anakinra as well in terms of switching off that hyperimmune response, which causes a lot of tissue damage and potentially pulmonary damage. And so conceptually, there potentially is some differences in those. I think you can't really rely on those concepts translating into actual benefit. And there was a lot of, I think we've seen that with tocilizumab, there was a lot of hope that that might be really useful. But, recent information that's come out of the trial from the drug company there has shown they weren't meeting their primary endpoint for mortality. So, conceptually there is some differences, but it's hard to really predict how that will pan out in properly done randomized controlled trials.
Yeah. So, Phil, I mean, thinking about that, do you think that there's likely to be a difference in terms of COVID-19, both in terms of getting it and in terms of severity between all the different biologic agents?
Yeah, look, I think there will be. We've already seen early signals of that in the published data from the rheumatology registry. As our numbers increase, I have little doubt that we will see differences between them because we actually have a relatively broad range of targets. We've got co-stimulatory inhibition, we've got IL-6, we've got IL-6 receptor, and then we've got IL-6 molecule, and we've got fusion protein TNF, and we've got monoclonal TNF, and then we've got B-cell depletion, and then, although not so widely used in Australia, but we've got data on, BLyS inhibition. We've got belimumab data out of the US and out of Europe. So, look, I think I am confident to say that we're going to see differences, and that's going to come out when we're able to publish our much larger data set, which we're currently analysing. And then it's going to be interesting because these drugs have different half-lives. Rituximab obviously has got a very long half-life compared to an agent such as etanercept, which would last for a week. And then potentially we're going to have to think further and try and increase the nuance of our approach to these agents. And I wonder if we're actually going to see. So, to give you some context, the American College of Rheumatology's advice is when people become infected is to stop all agents, but perhaps as part of a shared decision-making process, you can carry on with IL-6 inhibition. Now, I wonder if in time with the data, there are going to be other things added to that, other agents that potentially shown to be protective, and maybe IL-6 is going to be taken off that list. I think, as the numbers increase, and there are, ours is certainly not the only group thinking about this. There's no doubt that the companies are thinking about this from a safety point of view, because this pandemic ain't going away anytime soon. So I think that in a matter of time, we're going to have lots of different sources of information, and that will help to guide differences between biologics.
So it sounds like while we can make educated guesses about potential risk and benefit in both the situation leading up to potential infection and then during infection, based on the immunology and based on what we know about the diseases we're treating, but also COVID-19 in general, we can make best guesses. But in reality, we are also going to need to see that real world data to be able to know where the risk lies. It's a complicated situation.
Yeah, absolutely. And as we talked about right up front, these things are all within a context of what's happening around you. Your considerations about what to start and when are very different if you've been community transmission free for 100 days like New Zealand was up till recently, as if you're sitting in the Austin outpatient clinic in Melbourne right now. So it's tempting to think about, odds ratios and agents and mechanisms of action, but they all sit in a much wider context that I think is really important not to forget.
Absolutely. And I think, like Evan said at the beginning, it's we really just can't forget the simple stuff that is really what's going to get us out of this mess in the first place. So thank you very much to both of you for joining us today. It's been a fascinating conversation, and I'm looking forward to seeing how this all evolves in the next few months.
Thank you.
Thank you very much.
The views of the host and guests on this podcast are their own and may not represent Australian Prescriber or NPSM Medicine Wise. I am David Lear. Stay safe, and thanks for joining us once again.